Hello, my name's Patrick White. I'm the president of MedAxiom. MedAxiom's a peer-to-peer network of about 325 cardiology programs from around the country. We bring them together for educational programs. We have a very robust interactive database and bring people together to share experiences to drive improvement in quality and efficiency throughout the systems. My background is I worked at the Henry Ford Health System for 13 years, the last 5 of which I was the administrator for the Department of Internal Medicine. Spent 12 years as the CEO for Michigan Heart, a 36-member cardiovascular program in Ann Arbor, Michigan. In the last 11 years, I've been with MedAxiom. So of our 325 programs, what's been interesting is 10 years ago, almost all of them were single specialty cardiovascular programs, professional only, and in the last 10 years there's been quite a transition to the point now where 70% of our programs are integrated, meaning they're either owned or leased by hospitals or health systems or foundations. So that's been a major change. But what's really interesting is a lot of those groups, as well as a lot of our private groups, are now managing the cardiovascular service line at the hospital. So now we're focusing more time on the facility side, learning how that works, helping to improve quality and efficiency on the facility side. And I don't think there's a C-suite executive in the hospital out there that can impact quality and efficiency without having good partnerships with their physicians. And that, in many cases, means incentivizing them. Physicians are under a lot of pressure. They've got to see patients. How on earth do we expect them to start focusing on that facility side? So there have to be incentives. So that's been very productive. We've heard some great stories about improving, for instance, same-day discharge of PCI patients, especially using radial artery access, extubating patients in the cardiac OR, resulting in lower length of stay and improved lower expenses and improved quality. So those are great stories, and those continue to emerge. But now what we're also seeing in this era of accountable care organizations, and more importantly with bundled payment projects, physicians are getting involved not only in the facility side but also outside the hospital. So in this transition of care from hospital to nursing home, hospital to home, et cetera, physicians are getting more involved because some of them are taking some risk by participating in the bundled payment programs. And we've actually partnered with a company called Remedy Partners to get about 50 of our programs that are looking at that exact opportunity, where they have the option of choosing from about 48 DRGs, and they have the option of managing from day of admission through 90 days post-discharge, taking risk for everything that is included in that package. And of course, they take a bit of a discount from what Medicare would otherwise pay, but anything that they can save, they get to split with Remedy Partners. And what's really interesting, the reason that we see that opportunity is when you look at that care for a heart failure patient, for instance, Medicare will cover 29 days in a skilled nursing facility after discharge. And as you might guess, they'll cover 29 days. That's about the average length of stay for a Medicare patient. However, Medicare managed care, that length of stay is about half of that. So we know that there's opportunity, and there are other aspects in dealing with that transition to care where physicians can get involved. There's some incentive. They understand that what we currently have in our current healthcare delivery system is just not sustainable. We've got to change. And this is an example of a great opportunity for our physician leaders to roll up their sleeves and help design a better way of delivering care. And that does improve quality and reduces cost and improves efficiency. And I think when you look at what we need for transitional care, we definitely need a better IT system. One system doesn't talk to another system very frequently or very effectively. That's clear. We need tools. There are tools that perhaps make that more efficient. We need physician leadership. We need physicians to roll up their sleeves and help design these new systems. So if we're going to make a difference, it's not going to come quickly, but we know that our current system is unsustainable, and we've got to be able to change that delivery model.